Good afternoon, everyone, and thank you all for joining. I'm Dr. Deepika Chabra from Jagsonpal Pharma. We are pleased to bring to you ISAR Haryana's Inspire and Ignite Series 5, that is Understanding Male Infertility today. So with the faculty and the chief guest here today with us, we now begin the session. I'll hand over the session to Dr. Jyoti Malik, Chairperson Haryana Chapter of ISAR and Director Roots IVF Infertility Institute JJIMS, that is Medical Superintendent of JJ Institute of Medical Sciences at Bahadurgarh. Over to you, ma'am. And thank you all for joining
so
today.
Much. Thank you. Yeah. So on behalf of ISAR Haryana, Prayas Evam Vistar, with the motto of these lines of Prayas Evam Vistar, we, with our new team, dynamic team, we bring to you this another Inspire and Ignite Series 5 with a focus on understanding male infertility. And with the blessings and with the support of our national team, our National ISAR President, Dr. Ameet Patki, sir, Honorary Secretary General, Dr. Asha Baxi, ma'am. We thank you for giving us the support and always the whatever we advices that we need from the National ISAR. We are lucky to have you as our mentors. And with the team ISAR Haryana, with me as the chairperson, Dr. Meenu as our secretary, Dr. Manju as the clinical secretary, and Dr. Lakshmi Goyal as the treasurer, we feel pleased to bring to you this monthly series of Inspire and Ignite. And it is actually indeed an honor to have none other than Dr. H.D. Pai, sir, as our chief guest. And sir is, it is actually indeed it is an honor actually to have you here on this platform, sir, since you are holding such a big position. You are a trustee of FIGO Asia Oceania. You have been the immediate past president of the largest society of world, the FOGSI. And you are the president, professor of the reproductive medicine, DY Patul Medical College, founder and medical director of the Bloom IVF groups, and the chief administrator of the FOGSI Manyata project. Sir has so many awards, so many achievements, and whatever, I think now the sky is the limit. There is nothing left for you to touch, I suppose now, sir. And you are in spite of being on such a topmost position, you are so very down to earth and so very approachable, so very humble. So that is the best and the most important quality that you have, apart from being a great teacher, a pioneer of whatever comes comes in the science. You go there, you learn it, and you teach it. So it is actually indeed an honor to have been associated with you, to know you, and to have you today on this platform. We would like to have some opening comments from you, sir, Dr. Pai, sir.
Thank you, Dr. Jyoti. You're a dynamic person, and congrats for being the chairperson of the Haryana ISAR. And Dr. Meenu, one of my students who is now dynamic and leading. She is your secretary. So I can see her. Hello, Meenu. How are you? Everything okay?
Thank you, sir.
Then Dr. Manju Dagar and Dr. Lakshmi Goyal, who is treasurer. Dr. Manju Dagar is the clinical secretary. And, my very good friend, Dr. Sunil Jindal, is one of the leading male specialist andrologists. He is going to talk to us. And I would like to pay my respect to Dr. Ameet Patki, our National ISAR President, and Dr. Asha Baxi, who is the Honorary Secretary General of the ISAR. And I think today's program will be moderated by Manisha Mehta and Meenakshi Mehta. And, I think I can see some more people. So I've just... would like to thank the Jagsonpal also for doing this program. And basically, I would like to say 3-4 things that, of course, ISAR has now grown quite a lot. And, I was just giving a talk yesterday on the future of IVF. Is it bright? So, the conclusion was that it is very bright. So in all aspects, in terms of growth, in terms of technology, pregnancy rates. I think all of us have selected a very good line, I must say. So it's going to grow in a big way. It's going to bring more happiness to patient, more happiness to doctors as well. So I think overall, the future is very bright. We have to just stay properly compliant and, structured. Of course, some of the excitement which was there, of course, when I started it right from the beginning, new things came in, but I suppose new things will keep on coming. Yesterday when I was being a talk, Dr. Krishna Kumar gave a talk on future of hysteroscopy, and he showed us a hysteroscopic resection where, the artificial intelligence, when you are cutting, it gives you a red line. So as you are cutting, it gives you green line, green line, green line. When you come to the end, it starts giving you red line. So it's a new AI technology. By looking at the video, the machine tells you when to stop cutting. So, I thought that there is nothing new coming in hysteroscopy. Suddenly there's something new. Then I saw another technology on the net where, they were doing the robotic surgery in the uterus. They was operating here. You cannulate the tube through the operating channel. So, you go to the ostia through that camera, and then through the another channel, I was totally like psyched, with some new technology. So like, the technology keeps on advancing all the time. Maybe someone saying, Doctor, bhai, apan embryo transfer under vision karenge to. So now with this chota camera, so in the future we will have the embryo transfer chota camera. वो अपना डाला और साइड से कैनुला करके डाल दिया बराबर under the vision. So these are all new things that are coming up, and if you are compliant, so compliance is going to be very important. But I feel compliance will give rise to more profit, more people coming in, more standardization. So I think all of us are in the best line. Better line than the endoscopic surgeon, let me tell you. So, because in the endoscopy, there is an alternative tech. So I always feel, if you look at endoscopy, okay, laparoscopy क्या है? जमा नहीं तो खोल के करो ना, पेट खोल सकते हो ना. So, but IVF के लिए alternative नहीं है. There is no alternative to IVF. In endoscopy, you can open and do it. What's the big deal? Or robotic surgery, जमा नहीं, पेट खोल के करो ना. So laparotomy is always there. But in IVF, there is no alternative. So it's a fantastic line. And the new applications that are coming up is going to... So male infertility is again a big, huge thing. So when I was just now, the Dr. Rupin Shah ka message aa gaya mere ko ki he was in Aspire, and there he saw this new technology where the testicular tissue, you can pick up the motile sperm or a non-motile sperm by using AI. नहीं तो ढूंढना पड़ता है ना. So the machine tells you immediately within like 2 minutes, it tells you where the sperm is, and you can pick it up. So he said, Rishikesh, please, ये number है, ये वो आदमी है ऑस्ट्रेलिया से, उससे ये टेक्नोलॉजी खरीद लो आप. So it's a... So before I end, because I don't want to take your time, so दो मेरे लिए important conferences are coming up. One is the H3 conference, which is there in Jaipur. तो हमारा सबका कॉन्फ्रेंस है, प्लीज आना उसके लिए, क्योंकि आजकल इतने कॉन्फ्रेंसेस हो गए कि हमको टेंशन है कि कोई आएगा कि नहीं. And of course, the All India is doing very well. I was just now sitting with the team only. We are already gone across the 400 registration mark. We are expecting, बोलते कि 12, मैं वाला 10 के बियॉन्ड मैं कंप्यूटर को बंद ही कर दूंगा. 10,000 से मैं नहीं. सोनू निगम को मैंने ऑलरेडी बुक किया है. And the other one, I wanted to bring Sunil Jindal with his lovely voice. He would have been a better singer than. But we are looking for one more person, the multiple. ये लोग सब लाखों में ही बात करते हैं आजकल, और बड़े सिंगर तो करोड़ों में ही बात करते हैं. तो anyway, we are very excited that we are looking forward to all of you coming to Mumbai. Mumbai has become fantastic, beautiful new roads, lot of buildings. One of my friend had come from Bangalore. He said, "Sir, इतना city इतना change हो गया, बहुत नए metros आ रहे हैं." तो the city has suddenly become fantastic. So I would like you all to come and enjoy the city. जो BKC जहाँ हमारा कॉन्फ्रेंस है, उधर कम से कम 40 तो ब्यूटीफुल नए रेस्टोरेंट्स है. और बाजू में हमारे जियो को लग के मॉल है, नीता अंबानी ने बिल्ड किया. मेरे को टेंशन है कि आप सब मॉल में ही रह जाएंगे, कोई ये साइड में आएगा ही नहीं. इतना ब्यूटीफुल मॉल बनाया हुआ है. तो एनीवे, thank you very much, Jyoti, for I can keep on talking, so, I'm grateful to you and wish you the very best.
Thank you so much, sir. It is always, it is never ever a chance when we don't learn from you. You teach so much, even in your such a simple language, you've told us so much, whatever new has come. So thank you so much, sir. It is always a pleasure to have you, and we would love to have you whenever possible, whenever your time allows. Thank you, sir.
Thank you so much, sir, for your blessings.
Looking forward.
Thank you.
Jaldi.
So for this, our male infertility section, we have the conveners. We have our chairperson for the male infertility committee. We have Dr. Manisha Mehta. And we have the co-chairpersons, Dr. Sonam Sachdeva and Dr. Shweta Gupta. So welcome to the male infertility committee and welcome chairperson, Dr. Manisha. And over to you now to take it further from here.
Okay. So a very good evening, everybody. We'll not be wasting our time, and I want to, invite Dr. Sunil Jindal in for the session Understanding the Basics of Male Infertility. The chairpersons are Dr. Manju Khurana, Dr. Prabhjyot, Dr. Meenu, and Dr. Kunika. And over to you, Dr. Sunil. But before Dr. Sunil starts, I just want to, tell something. He has been my senior. He was in MAMC, and he's a graduate and postgraduate for MAMC. And by his MD, MS degree, he's a surgeon, but he is, a real person who really loves to talk about infertility. And it's not just the talks he gives, he's so much active on social media. And I love to see his videos. Over to you, Dr. Sunil.
Thank you very much. I hope you can hear me. Yeah, and thank you very much. Pleasure to be here. Thank you, Dr. Jyoti. Thank you, Dr. Meenu. Thank you, Dr. Meenakshi. Thank you, everybody. And of course, Dr. Rishikesh Pai for always giving these kind words. So I have wanted to speak on male infertility over here. And I would love to speak today on the topic of male infertility. I have tried to bring in a lot of things which are pertinent and about 5 different things which I'm going to speak about as the learning objectives. So we have a particular set of objectives we have. Number 1, WHO has updated the reference limits of semen analysis results. And let's understand how could we adopt them. Number 2, new diagnostic tests go beyond the routine semen analysis, as you would normally see. Antioxidants play a beautiful role. I luckily in the last 4 years have had about 19 publications on different aspects of andrology and about 4 textbooks. Chapters in them. 2 of them are international textbooks. And this has made me realize very, very deeply, apart from the practice which I have, that andrology contributes to about 50% of what males need of infertility. And this is something which every gynecologist should know, because this is the way they actually could enhance their own practice. Number 4 is, let's learn about what is available for azoospermic men seeking fertility treatment and how spermatogonial stem cells is going to change the way the world is at the moment, not later, but very soon in the next 10 years. So I would begin by talking about, in the first slide, the secret number 1 of semen analysis. One particular thing which people think is so simple, but let me be honest with you, it is something extremely complex. And people do not realize that a semen analysis by WHO criteria is something which they need, because that's the only way they would know what they need to do for this particular man. The second important thing which we have over here is that you may have a lot of sperms in number, but the functionality of the sperm is what is important. देखिए, आपके पास में एक फौज 100 आदमी की हो सकती है, लेकिन अगर उसमें 100 फौजी होंगे, तभी वो 100 आदमी की फौज होगी. Otherwise, if there are only 20 Fauji's in that, it is only 20 people. So though the number of sperms which you have may be, say, 100 million, but if the functional sperms are only 20, then the functionality is what matters for you to have a baby. The third important thing is antioxidants, which once upon a time we used to think as placebos, has changed phenomenally into something which has become a mainstay in treatment. A mainstay in treatment, which, well, needs to be practiced by everyone. 70% of azoospermic men can have their own children. I, from morning, have done 3 microTCs. I was just rushing somehow that I should find sperms to speak over here. And 1% of Indian population is azoospermic. And every azoospermic deserves their own children. The fifth important thing which I'm going to talk about is the future, how bright it is, and how it's going to change everything the way it lands and is present at the present moment. So let's come on to, first of all, semen production. So it's very important for us to understand that spermatozoa are produced within the seminiferous tubules of the testes. They go into the epididymis where they are transported and stored. They move into the accessory glands known as the seminal vesicles and prostate, which give the liquid form of semen, which not only gives them the acidic pH, this also gives them something very important. It also gives them nutrition. So the composition of semen is simple. Sperm with secretions from seminal vesicle and the prostate. So I'm going to bring over here the reference values the way they are at the moment. 5th percentile, which is if what they did in the semen analysis of WHO is they calculated out of 100 people, those who would get their woman pregnant within 1 year, and they would make a percentile of that based on the semen count. So the 5th percentile is not taken as normal. Please get this thing. 5th percentile is just a percentile. The 50th percentile is what 50% of the men had. So if I go on to the percentile, I will see that the WHO 2010 has 1.5 ml, while WHO 2021 is 1.4 ml. 15 million per ml, 16 million per ml. Total sperm motility 40%, in the new one 52%, and the vitality of the sperm from 58, it has come to 54. But I'd like to add 2 basic things which have come into the WHO manual, because I've read this thick manual and I've presented it so many times. And we're also writing a book with Dr. Ashok Agarwal and GAF team, which is a book on the new semen analysis. So I'm going to speak about the new semen analysis. The new semen analysis has included semen DNA fragmentation as a test which can be recommended in the future in patients, which was not done earlier. And it also brings in ROS, reactive oxygen species, as something which can be recommended, though experimental at the moment. So what is the reason for the low cutoff? Now, एक क्वेश्चन मुझसे सब पूछते हैं कि अब ये 4% क्यों हो गई है morphology? And this is a question which is asked from so many people. It is not that the morphology is being considered separately. It is just that the criteria for morphology assessment has changed. And it is done by Kruger's criteria, where every sperm is measured. So the laboratories, which mostly do morphology, do not stay in the slide and look and measure 200 sperms. And this is the reason that most of the semen analysis are not done as per WHO criteria. Now, this is the way I was talking to you about, that the head is measured, the head width, head length, midpiece and tail, and only those sperms which come in the strict criteria would be considered morphologically normal. And that is the reason 4% has been taken as the morphologically normal criteria. I bring this over here to you because this is not important. This is something which every gynecologist should know. And it's very pertinent that the semen analysis done at your center or wherever it is done at a pathological center or your laboratory needs to be done properly as per the WHO criteria. So let's move on to the next slide. And the next slide talks about the 5th percentile. Now, we are basically focusing on the 5th percentile. So it is not that the WHO, by the way, the WHO latest edition has also said that the 5th percentile does not mean normal and not normal. It just means the 5th percentile. People at the 5th percentile may not get their women pregnant, and those below, well, it's difficult, but it is just a 5th percentile to talk about. It's not normal and abnormal. So this is not like any other blood test where you could say, ye normal hai or ye abnormal hai. It is something very different compared to that. So let's move on to what is beyond semen analysis. So there are 3 tests I'm going to talk to you about. And I'm going to talk to you these 3 tests because it's important. Number 1, semen DNA fragmentation. Number 2, measurement of reactive oxygen species. And number 3, Y chromosome microdeletion. So let's just dive into this. So sperm DNA fragmentation, the background is that normal pregnancy will happen with a sperm which is non-fragmented. The second thing is you measure it in the semen. The third is a lot of tests are available. Tunnel is the gold standard, but you can also use the halo test or the staining test. And where is it? What does DNA fragmentation cause? So it causes unexplained infertility, recurrent pregnancy loss, and poor outcomes in IUI and IVF. Incidentally, I have been a part of the largest review article the world has ever had. And it's a beautiful review article to read on sperm DNA fragmentation. So as practitioners of infertility, or as gynecologists who get patients of infertility, it's important that you should have a basic idea of sperm DNA integrity testing. I will add 2 things to it. Number 1, this is done on a fresh semen or on a semen sample which has been frozen in liquid nitrogen. So anybody who's carrying the semen sample from your IVF center and taking it to another big laboratory has to take it in a frozen state, which they could thaw. There's so many laboratories today doing this test by taking the sample on liquid carbon dioxide. That is a big no-no. This is one thing which I'd like to give to you over here. So moving on to the next, sperm DNA fragmentation is also important because if you look at data, I've tried to simply present it over here. Live birth rate in intrauterine insemination may be up to 15% in a normal sample, but if DNA fragmentation is high, it can get reduced to 1.5%. Number 2, the interesting thing is that if you do an IVF in a patient who has a high DNA fragmentation, the success rate is only 26%, while the success rate of ICSI is 42%. So this is a massive change because otherwise it should be equal in a normospermic sample if DNA fragmentation has not been checked. But why does this happen? Well, it happens because of 2 reasons. In IVF, once you have washed and kept it in the dish, you would have even more DNA fragmentation, 1. Number 2, if you place it in immediately, the bad DNA or the fragmented DNA can be repaired by the cytoplasm of the woman's egg. So the younger the woman, the easier it is to repair, the better the results, and the sperm can be repaired. तो देखिए औरत का जो रोल होता है ना, वो सिर्फ वैसे हेल्प करने का नहीं होता, ये अंडे पुअर स्पर्म की भी हेल्प करते हैं. तो इंपॉर्टेंट है डीएनए फ्रेगमेंटेशन के बारे में आपका जानना. Now let's move on to the next slide. You can do the quickest and the easiest test for sperm DNA fragmentation is the halo test. So sperms with fragmented DNA do not show halos. They represent DNA strand breaks. Now, what you see is sperms and spermatozoa. It's quantitative. It depends on your own laboratory. When we started doing DNA fragmentation, we had to, after doing tons of samples, make out what is the percentage which we should consider is more than normal, or which would we say is a sample which is a sample with more fragmented DNA, and it came to about 30%. But every laboratory would have it different. So now I'm going to come to the third test, and the third test is Y chromosome microdeletion. Well, the background is that deletion is linked to spermatogenic failure. And who? Severe oligospermia and non-obstructive azoospermia. What do you measure? You measure the PCR of the long arm of Y chromosome. What's the specimen in which you do it? Peripheral blood. And what's the clinical significance? It has a diagnosis and a predictive value for sperm retrieval. So any patient who comes to you with Y chromosome, with azoospermia, before you take the patients up for retrieval, please get a karyotyping and Y chromosome microdeletion. If Y chromosome microdeletion has deletions in the areas of A and B, there will be no retrievable sperm. So there is no point of going ahead and doing an ICSI in these patients, and you could avoid this ICSI. However, if you find them in the area of C, AFZC, sperms can be retrieved in 70% cases. However, please remember, if a boy is born, he is going to have the same problem. So moving on to the next slide, I'm going to speak to you about oral antioxidant therapy for male infertility. Well, this is the Cochrane review. And what they saw was that the live birth rate and the pregnancy rates were higher and DNA fragmentation was less when oral antioxidants were given for male infertility. Now you would ask me why. See, 50% of infertility today with a normal sample is idiopathic. And 50% of this idiopathic is because of oxidative stress. And oxidative stress leads to DNA fragmentation. And the treatment of oxidative stress is, number one, removal of the stress, varicocele, infection, toxicity, pesticides, and giving a change in the lifestyle, which means food and exercise, and along with that, antioxidants. Therefore, because recurrent pregnancy losses do not take place, you will have a better live birth. Because DNA fragmentation goes down, you are going to have a better live birth. And more importantly, what you are going to have in these is a better pregnancy rate. So this is the Cochrane review I want to bring you here. Now, the rationale of this, I have spoken to you about. 30 to 50%, 80% of infertile men have elevated markers of oxidative stress. And what is it because of? Well, it could be because of so many things which are around us. Pollution, food, pollutants. देखिए जो स्पर्म होता है ना, इसका बहुत सेंसिटिव सी चीज है. It could be because of infections, diabetes, cancers, smoking, alcohol, drugs. Now, all these affect the sperm directly and lead to a situation where this sperm is affected. And so oral antioxidants have a role. Now, if the oxidative stress is high, you've got to treat the varicocele, treat genital infections, stop smoking, start medication. Any medication which is bad has to be stopped. Drug abuse has to be stopped. Systemic diseases need to be seen. Pollution needs to be less, and radiation needs to be stopped. Please test for leukocytes and infection. And what are the antioxidants which can be given? What I normally give after having been there in this line for a long time, in fact, it's been a privilege of being a part of GAF and the main group, because I've had this opportunity of interacting with these amazing people. And what I normally would give is vitamin C and vitamin E, which is the cheapest, folic acid, zinc, selenium, astaxanthin, coenzyme Q, lycopene, and L-carnitine. How long? Ideally 3 months. Could be given for a minimum of 2 months. And now I'm going to talk to you about the fourth issue, which is azoospermia. 1% of Indian population is azoospermic. And kasht ye hai कि any human being who has azoospermia is greatly pained. They feel inadequate. A lot of them go into depression. And when you start talking to these people, you realize the desire to have a baby of your own sperm is justified, and they should have it. And 70% of men can have a baby with their own sperm. This is the beauty of sperm retrieval. And in the future, even those in whom sperm could not be retrieved will be treated in this fashion. So this is just an amazing world. So let me bring on this slide. See, there are two types of azoospermia, obstructive and non-obstructive. So obstructive is where normal sperm production is taking place, and non-obstructive is where sperm production is deficient. I will not go into the details of this, but I'll just say simply that in obstructive azoospermia, the chances of getting sperm are very good. In non-obstructive, the chances are less, and even the fertilization and pregnancy rates are lower. Now, I'm bringing this slide over here. There are a lot of techniques which are used. So you could have PISA, percutaneous epididymal sperm aspiration. You could do MESA, mesoepididymal sperm aspiration. By meso, I mean microscopic. Now, MESA is normally done under a microscope. The yield of sperms is better, but PISA is simpler and can be done more easily by most. Next, you have TISA. TISA is when you put in a needle and you try to get sperms. The role of this in non-obstructive azoospermia is very less. In fact, just like the role of FNSC is very less. Then you have TISA, when you take out this sperm after giving a small incision. And the gold standard then is micro-TISA, where you open up the testes, view it under a microscope, pick up the sperms under a microscope, those tubules, take them out, use them, and finally give an azoospermic man his own baby. So I'm now going to show you a video of PISA. So if you can see over here, PISA is a procedure in which three things need to be understood. Number one, you got to see the most prominent area, hold it, feel it. I nowadays do an ultrasound and judge where my needle needs to be. Place in a BD syringe which has some media with the same insulin 24 gauge needle. Aspirate. Take out these sperms. And once you have got these sperms can be used for ICSI. Now, the second is, this is not a TISA, this actually is PISA. But supposing you have not got sperms and you have not been able to get sperms by a BD syringe, then the second method which I use as a routine is a butterfly, 22 gauge butterfly. And you have a syringe which is 2 to 5 ml. You'll have media in the tube. And once you have pressure, you would clamp, release, take out the material, and see if the material has any kind of sperms. So PISA has no role in non-obstructive azoospermia, but it needs to be used when in obstructive azoospermia. MISA, which is microscopic, is a procedure which gives better results, but then you have to do it under general anesthesia, and you've got to do microsurgery, and you've got to be a reasonably okay microsurgeon for that. So the third technique which we have is a TISE. This is a window TISE. So this normally would be done in hypospermatogenesis if you do not want to open the testes too much. And this procedure would also be done where in an obstructive azoospermia, you have not been able to get sperms by a PISA. So this was this. Now, the next I'm going to show is multiple biopsies. This is a very old video, about 12 years old. I don't do this procedure now from the time I started doing micro-TISE. But when I didn't do micro-TISE, what I used to do was, I'm showing you this procedure for you to understand that in non-obstructive azoospermia, you have a system where you could have focal spermatogenesis. So in a person like this, if you give multiple biopsies at different places and take the tissue out, it is possible that in non-obstructive azoospermia, you may get some tissue which may have, this I have left doing about 12 to 14 years back. But for people to understand, I have placed in this very, very old video which I had. So this is what you would use to take out the sperms. I was very lucky from 92 to 98 to have a consultant with this Professor Kaza, who went and got trained in the US, and the urology department, Azad Medical College didn't have a urology department. So the surgery department had the urology department. And he used to do microsurgery on the testes. And microsurgery on testes when he used to do regularly. I mean, so regularly, I cannot tell you. But after getting sperms, he would say, Jindal, I have found a sperm. And I always used to say, sir, what will you do with this sperm? It was only in 2004 when we started ICSI that I realized there was one place where this sperm could be used. And that's when we realized that these sperms picked up by microscopes can be used in ICSI to have their own children. So now let me come to the next slide, which is micro-TISE. See, micro-TISE is an amazing procedure. The beauty about this procedure is just one thing, that you've got to be very good in microsurgery. By microsurgery, I mean it's a different ball game altogether. I do laparoscopic surgery, I do microsurgery, I sit on ICSI stations and do ICSIs myself. Just because I love learning any technical skill which uses the fingers. But I was lucky to learn microsurgery during my training. I was lucky to learn laparoscopic surgery during my training. And this is something which changes the game. And what we do in this is that we open up and bivalve the testes. Then under a microscope and high magnification, we see if any tubules are thicker, which is going to predict and show to us that, well, probably these tubules will have sperms. We're going to pick up those tubules, open those tubules, take out sperms, and use it for ICSI. To give a baby to somebody who doesn't have sperms, it could be a cancer survivor, it could be Klinefelter syndrome, it could be just anybody. And this is a beautiful procedure to have. So now what do we do in micro TSA? So micro TSA is a procedure which I'm going to show you over here, where you're going to open up the testes. And after opening up the testes, you're going to take these sperms. This is the first stage from the surface. I have not bivalved the testes till now. And looking if there are any tubules which are thicker, which can be picked up, and which can be used to strip in and see if any sperms, if they are present. Now, if any sperms are present, these are the sperms which will be taken out and used to do an ICSI. Now, the beauty about this procedure is that you need two things for this: patience, and the patient needs to be in you as well as your embryologist. I have a beautiful set of two embryologists. I'm lucky, who have more patience than me. And the moment I say, is it ab kar dein bas band? So they say, ek sample aur le lijiye. So what happens is, they keep on goading you till you get these sperms. And the pleasure of having sperms in these people, I mean, it's amazing. So I'll just like to show you here how does it look. So if you can see over here, these are thicker tubules which we're going to pick up. And these thicker tubules are the ones which are going to contain sperms. So now, how would sperms look in a testicular sample? So this is how sperms would look in a testicular sample which has been cleaned. If you see over here, you're going to find these sperms which are intersped in this tissue. And these are the sperms which you would like to pick up. You can see two sperms at the top, but they are immotile. And you can see over here one sperm which is motile. So this is the sperm which we'd like to pick up and use and take it into PVP, place it in PVP, and then pick them up to do an ICSI. I was planning to go live on my channel in ICSI, and I was thinking that I'll go live because luckily now I have an amazing channel and God has been so kind and there's a lot of effort which I put into it. But then a place where you can go to millions of people with over 60, 70,000 live viewers of a surgery, two people to understand, is very fulfilling. Now I'm going to talk about how do these sperms. This is a very, very old, I think a 12-year-old video, which I had made. And I had made in a PISA sample. TISA is wrong, it was actually a PISA sample. And it was a very poor PISA sample. And a lot of RBCs came in. So looking for a sperm in this. So just picking up a sperm from this TISA-PISA sample and taking it in. And there it is. So I plan to go live, ICSI, and I think that would be wonderful. That would be wonderful. Semen retrieval live. So there was something that, I mean, there's so many laparoscopic surgeries going on live. I think let me go on for people live for this. That would be great. I just thought about it. Now, this is about, I think, 14 years back. We did a PISA of a patient who had smallpox. And I still remember, this was, I think, 14 or 16 years back. And to give this man his own baby was brilliant. And what I've realized is in the last so many years, this 1% population needs their own child. और कभी कभी मुझे लगता है कि जिनकी खुशियां आंखों में देख के, इनकी आंखों में आंसू देख के ये काम बड़ा फ्रूटफुल है, तो मुझे लगता है सबको इसमें हिस्सा करना चाहिए. This is another patient in whom we took a TSA, the first TSA I think we did. This is also about 16, 17 years back. The first TSA which we did. And 2 baby boys this person had. And this was lovely again. Now, this was a very interesting case. This was so interesting, I cannot tell you. This person I have known, very, very rich family. And the lady is not rich, very rich. She came to me and she said, I want to buy the most expensive sperm in the world. And I asked her, what's the problem? So she showed me the papers. And the papers had her son, who was hypogonadotrophic hypogonadism. So I said to her that I do not know whether it's going to be the most expensive sperm in the world. But yes, you definitely can have the most valuable sperm in the world. So there's a difference between valuable and expensive. So we stimulated, this was about 16 years back. So we stimulated him. And by stimulated, I mean we gave him HCG. And then we added HMG. And after about 4 months, I remember my embryologist telling me, sir, inke to sperm aa gaye. So we did the first ICSI. She didn't get pregnant. Did the second ICSI. And we placed in 3 embryos and she had triplets. So we did a fetal reduction. Triplets or quadruplets. I think 4 at that time we placed, because that time we just thought she's got to get pregnant. So we did a fetal reduction. So there was a fetal reduction and finally gave birth to these 2 beautiful babies. And this is the beauty. And from that day till now, it's not only a question of these hypogonadotrophic hypogonadism people getting children. It's also the fact that when the testosterone goes up, they have a whole different body image. Mustaches come, beard comes, sexual life improves. So it's a beautiful feeling for them. And then to have their own children is so beautiful. So this was another beautiful non-obstructive azoospermia, the first cancer survivor we did. So he was a cancer survivor, Hodgkin's lymphoma. And later on I came to know that इनके एक बाबा जी थे जिन्होंने इनको जब छोटा बच्चा था तो कहा था डॉक्टर अडवाणी के पास में बॉम्बे में जाओ. Was given chemotherapy, was azoospermic. Then I later on came to know, went to his Babaji, and the Babaji sent to me. And then we did an ICSI, a TISA ICSI for him. So in this micro TISA ICSI, this was long time back, we were able to get sperms, get them pregnant, have 2 children, and these 2 children were born. So at that time, that was in IAPSI cheese, the Times of India में आया था उस time पर, बड़ी खुशी हुई थी हमें. So now, with all these beautiful things about azoospermia, I'm going to come about the future perspectives of how the future is going to be phenomenally bright. See, just like you have prostate-specific antigen for prostate, just like you have CA125 for ovarian cancer, you also can have biomarkers which are going to tell you non-obstructive azoospermia, which are the sperms, which are the people in which you can expect to retrieve sperms. So you could give a better idea to these people of what are the chances of me getting your sperms. So the future perspective is number 1 that. Number two, the future perspective of male fertility preservation. See, if you have a boy of 14, 15, 16 who can ejaculate and give you sperms, it's great because at least you have somebody, you have that age that they could give you sperms. But supposing you get a child who's developed cancer before he can ejaculate those sperms, how would you preserve? So new prospects are coming into it. Number three, stem cells. Stem cells are and will be new agents for treatment of male infertility. And with genetic testing and the current diagnostics, a large portion of idiopathic non-obstructive azoospermia, and I would say obstructive azoospermia, oligoasthenospermia, low sperm counts, you would know the underlying disease why it's happening. And probably you would be able to judge better what could be done with them. So let's talk about genomics. What happens is that when you have a protein which is formed in the process of, say, spermatogenesis, and if some protein could be measured, and this protein could tell you that sperms will be produced or not produced, it could be something which is known as the omics. And these omics, which means genomics, transcriptomics, proteomics, metabolomics, are going to expand the vision of the way you would know about male azoospermia and oligospermia. Now, I'll give you a small example of a boy who is young, who does not produce sperms, has developed cancer. So if he's producing sperms, you can store his sperms. But if he's not producing sperms, you could store tissue. Now, this tissue could be used. You could take out spermatogonial stem cells from this, culture them to get sperms, or you could put this tissue and store it as a xenograft in an animal, autograft in oneself, and then later on take it out to get sperms from it. Or in the future, the way I envisage, you could have a pluripotent stem cell from, say, skin and make it into a sperm. So this is the beauty where the way preservation would be. Now, spermatogonial stem cells, if you could take them out and if you could process them to make sperms in the laboratory from these stem cells and use them to have your baby, this would be beautiful. And do you know, the beauty is that xenotransplant, functional genomics, in vitro generation of sperms, and male transplantations would be beautiful. But I'll talk about in vitro generation. In 2011, Takehiko Ogawa in Yokohama University did something amazing. Took mice who were azoospermic, took out spermatogonial stem cells from their testes, cultured them to produce sperms, took those sperms and inseminated mice and had babies in these mice. So these mice had small mice, but this has not been done in men as yet, but in the future it would be done. Another technology known as CRISPR. I've had this amazing chance of visiting a lot of CRISPR laboratories. थोड़ा पागल सा आदमी हूँ, जो नई चीज मुझे दिखती है उसको देखना चाहता हूँ. And if you can take out a codon, take out an area of the gene string, of the genes, replace them with different genes, you actually could have an embryo free of so many diseases, diabetes, thalassemia, or you could even generate designer babies, which probably will not happen because of so many regulations. And these designer babies, my goodness, would be like Sachin Tendulkar and probably Deepika Padukone. But this probably will not happen because of regulation. But a lot of diseases would be cured. And now in the end, I would come and bring you to a particular slide. Now please see this slide. A man and a woman produce a child. But if two men marry, at the moment, what would they do? They would, one man, मतलब सिक्का उछालेंगे, एक आदमी कहेगा स्पर्म मेरा यूज होगा, Or क्या करेंगे? They're going to get a donor egg, use a surrogate to have a baby, but in the future, these two men, one would use a sperm, and from the other, pluripotent stem cell and ova would be made, and they're going to have their baby, which would be in a surrogate. The two men are going to have it. And for two women, one could give the egg, and the other's pluripotent stem cell would be produced, would be used to get a sperm. A baby would be made. One of them would take them into the uterus, their uterus, to have a baby. But the beauty is they would never be able to have a boy. And this is the beauty of the way technology is going in. I have told you about the future, and I really thank you for this beautiful presentation and time. And I'm grateful to you for spending this beautiful time with me at this moment. And I am sharing this from my amazing studio. And I've tried this new system, which I've tried for the first time, where I'm presenting a slide along with so many graphics together. And I'd love to be there with you. Thank you very much. If there are any questions, I would like to answer them.
So much, Dr. Jindal. It was indeed a very interesting presentation. And in fact, you made our work very easy. We were going to take the panel on the questions, the various scenarios, which I think have already been discussed, but still, we are going to take. Thank you so much. It was a pleasure having you with us in the Haryana Society. Thank you so much.
Thank you very much.
Yeah, thank you, Dr. Jindal. It was actually very. I mean, we were all wonderstruck by your studio, by your way of presenting, the way you have shown from the sperm till what can be done at the ultimate, the two female or a male, and then how the science, the future of science, or the future of male fertility, and how deeply involved you are into micro TSA, and how it sorts of moves into, I mean, how you put your soul and heart into everything. So over to Dr. Manisha now.
So it's a great pleasure to invite Dr. Manisha Mehta. She is our good friend, and she is the director of Apex IVF Center, Sirsa. She is a leading infertility specialist over there, and she is the past secretary of Haryana ISAR. She is from our own society. So let's now give a big hand to her. And next is Dr. Meenakshi Mehta. She is graduated from our own college, PGIMS Chandigarh Rohtak, and she did a lot in this field. She is the life member of many auspicious organizations. She won the prize and poster presentation and has many publications. She is the past secretary of ISAR FOGSI. So now let's join the hand with both of them to listen a good panel and good cases on the male infertility.
Yes.
Thank you, ma'am, for the introduction.
So this is case 1. It's a case of a 28-year-old couple who's married for 3 years, primary infertility, unremarkable medical history. Wife has all reports normal with regular periods. That I'm sure in this whole presentation of 6 cases, wife to normally hai, because we are here to discuss male infertility. So we'll skip on that. Okay. So her HSG is also normal, but husband is a software engineer. He's social alcoholic and an occasional smoker. The semen analysis report, you can see the total count is approximately 56 million per ml, which is quite okay. The motility is 35% and morphology is 2% normal. So, Dr. Preeti, can you please tell what is the diagnosis? What are the treatment modalities? I mean, are you going to suggest this patient in IUI, IVF? What all? In a just quick thing, because
Since the male partner, he's a occasional smoker and like drinks occasionally, so it's a case of teratozoospermia, and like I would like to do some lifestyle modification first, and would like to do a repeat semen analysis. And in the meanwhile, patient can be tried over the ovulation induction and time quarters. If that doesn't work, then we can go ahead with IUI for 3 cycles. And obviously with like antioxidants and lifestyle modification, after that, we can go ahead with IUI if the couple doesn't conceive within 3 months of ovulation induction and time quarters.
Yes, absolutely. You've almost covered everything, but I want to take your attention to something more. More than the smoking and the social drinking.
Yeah,
One
he's a software
very
engineer,
important.
so like,
Yeah.
yeah.
I
So-
mean, some we forget that how much, you know, this, it's not just the people who are doing the jobs on computer, but the
Yes.
mobile and how it is eating the head of each and every person.
Yeah.
So this is the main cause. I mean, very surprisingly, in my OPDs, I usually say that it is more probable to have a good semen analysis report from an oldie than this new generation. This is
Right.
something, yeah. So that is one thing, that screen time should be taken care of by everybody.
Yes, ma'am.
Lifestyle modifications, yes, we've here they are showing smoking, alcohol, fine, but the stress factor, which is very much underestimated, because jitna, you know, type A personality, and even for our children, when I feel ki hum itna zyada unke upar, you have to be achievers, but this achieving is causing so much of stress. So this is one very important thing. And one more last thing, which I feel is sleeping on time.
Yes, ma'am.
Because ये जो रात को लेट सोने का कॉन्सेप्ट हो गया है ना, तो उसमें क्या है कि आपके गुड हार्मोन सेक्रेट होने बंद हो जाते. There's this window जब 9:30 to 3 o'clock, 4 o'clock तक everybody should sleep. This is also very important.
Yes, ma'am.
Anybody else who wants to add on? Then we take the next question. Yeah, antioxidants, he did talk about L-carnitine and everything. Antioxidants do have a role. And similarly, the food we are taking in is very much deficient in micronutrients. So wo bhi dhyan rakna.
And
Over
we are
to you.
consuming-
Thank you, ma'am.
Thank you,
Now
ma'am.
now I would like to invite Dr. Priyakshi Chaudhary for the next question. Hello, Dr. Priyakshi.
Hi, hello everybody.
The next question is a 35-year-old couple married for 7 years, case of primary infertility. Husband is farmer by occupation, hookah smoker, occasional alcoholic. Wife, she has scanty periods, dysmenorrhea. On HSG, her right tube is patent and left cornal block is there. The semen report is, other parameters are normal, but the significant finding is the persistence of 3 to 5 round cells per high power field. And they have a history of pain during intercourse. On examination, this is the picture of the inflamed prepuce.
Yes.
Now, what is your diagnosis?
So here, looking at the case scenario, we absolutely know both the factors are responsible, male as well as female factors. So for male factors, since he is a hookah smoker, occasional alcoholic, so of course the lifestyle is having a negative impact on the semen or the fertility. Next is the semen analysis report, which suggests leukocytes are the round cells present. So I think there's a possibility of infection or inflammation, whereas the pain during intercourse also suggests could be an inflammation and infection. So we'll have to look into some urological scenarios also here. And for the female factor, since the HSG suggests right tube is patent and left is not, so here, so we have about 50% chance of male getting fertile, because of course one path is of course hindered. Secondly, she's presented with scanty periods and dysmenorrhea. So we'll have to look into the hormonal factor also, or any uterine abnormality which suggests dysmenorrhea. So also the visual examination or the picture that is provided is more looking like an inflammation or maybe phimosis. So what I would recommend is that lifestyle modification, of course, for Mr. X. and we can put him on some antibiotics for inflammation, or a urine culture or a semen culture, which would give exactly what is the cause. And we can also go for neurosurgeon opinion in case of any phimosis or any other abnormality. And for the female part, I think we can go for hysteroscopy or an examination, uh, and the hormonal investigations, of course, uh, to find out why the pain and why less scanty periods here.
And
That,
what antibiotic would you suggest in this case? In
I
pyospermia?
think I'll in fact wait for both your urine culture and semen culture report, and on that basis we can go for antibiotics, because anyways antibiotics are used so heavily. So I think it's now time we wait for all the culture reports and then go for antibiotics rather than just blindly giving doxycycline that we normally use so
That's a problem.
widespreadly. So I'd actually wait for the semen culture and urine culture report.
And how will you differentiate between the immature germ cells and leukocytes? Any test?
So yes, morphologically, we can, versus morphology, we can look into it. The immature germ cells would actually be very smaller in the size. Will be round, high nucleus to cytoplasmic ratios with small granules. Whereas the leukocytes, of course, we know they're very spherical with prominent nuclei, more cytoplasm and distinct granules are present. And also we can go for staining like germ cell specific staining or leukocyte specific staining that we normally do. So that is how we differentiate between the both, the staining techniques and the morphology.
Okay, there is a one ENDS test, which is a peroxidase test.
Yes,
The
that is
neutrophils
leukocyte stain specific staining testing.
Yeah.
Yes.
And the treatment protocol antibiotics as per the Culturepedia.
Yes.
And we can go with the antioxidants to improve the other parameters, and anti-inflammatory can be given.
Yes.
And one thing specifically which is advisable in these pyospermia patients, basically the infection rests in prostate gland. So you should advise the patient to frequently ejaculate the sample every third day. So there is no remnant infection present in the prostate gland. And that wise we can able to achieve the 100% cure in this patient.
Yes.
Over to ma'am for the next question.
Yes. I just wanted to add one thing to your thing here. One thing has to be remembered, that the male urinary tract is much longer and it's not straight. So usually the antibiotic course, whichever we are giving, should be given for a longer time. Like if I get an infection of a female, usually 5 days course of antibiotic according to the culture report is sufficient. But in males, at least 14 to 21 days also it is required. So that's it. Now coming to the next question, Dr. Meenakshi, please. Yeah. So I'm going to, this question is for Dr. Jyoti Gupta. I hope Dr. Jyoti is here.
Yes. Yeah.
Yes. Yes. So Dr. Jyoti, I'm going to skip the female part because wo to theek hi hona tha.
Okay.
Now coming to the sperm analysis report, the concentration is 12 million per cc, motility is 30%, morphology is 4%, which is okay. Volume is 3 cc, but on examination, we see a large left varicocele, right? So now, even the second examination report, you can see it's also, just suboptimal. So now my first question is, when you see a varicocele, what do you suggest? This is my, genuine question which I'm asking, that normally as a gynecologist or as an infertility specialist, do you suggest varicocelectomy? Yes or no? Number two, what is the cause for the altered report in such a case? Number three, is there any role of medical therapy as well in a case where we can obviously find a cause for the low count and motility? So, over to you.
Yeah, as you discussed the case, hi everyone. As you discussed the case, this is the case of OAT because morphology is less, motility is less, and the count is less. I won't suggest varicocele surgery in grade 1 or 2, but it has a role in grade 3 and 4. Since it is a large varicocele, even the patient is, it's visibly, yeah. So I would suggest a varicocele surgery. And in varicocele, if there's a large varicocele, there is an increased temperature around the testicles that causes ROS and leads to decrease count and motility and morphology. So in such patients, even if we go for DNA fragmentation, it seems always on the higher side. So I don't think medicines has much role in grade 3 or 4. So if we take such patients, even for IVF, we see that they sometimes the fertilization is on the low side and embryo formation is not good. So it's better to suggest surgery in such patients.
Okay. So now, yes, you said the reason for the poor count morphology, motility is the high temperature.
Yeah.
Although I differ from you at this point, that it is not just grade 3 and 4 where the temperature would be harmful, because any more vascular structure around the testes is definitely going to increase the temperature.
Yes.
Me personally would have gone for the surgery for a varicocele if it is causing infertility. Suppose if it was, yeah. Because this patient, I mean, even if it was not a large varicocele, but if the lady is not getting pregnant with whatever it is, if the semen is not good, I would suggest varicocele surgery. But in my center, what I personally do, I'm not saying it could be a practice followed by everybody. Whenever I have to post a patient for surgery, I usually like to freeze samples before I take. Because suppose something happens, I mean, anything is possible in this world, so at least sperms hone chahiye. That is my one thing. And now, since we were talking about temperature, I would not like to pass the next question to Dr. Meenakshi before I speak about this thing, that the diapers people are using left and right also lead to increase of temperature of testes. And we all know the testicular temperature has to be 2 degrees less than the body temperature.
Yeah.
The mobile usage is also causing increased temperature. So these things also have to be taken care of. And also we know that microplastics are being found in semens. So we as people also have to take care. Keep plastic bottles we have to stop using so much. I mean, it's not just about a baby, it's about everything. Yeah.
And
So-
even after COVID, we see that the patients' sperm parameters are less because they're keeping their laptops at home and they are working. So this is common in corporate these days. So.
Yeah, no, it's not just the laptops. See the children. See the children. जब उनको पढ़ाई को दे दी तो उसके बाद तो वो छूटा ही नहीं. So over to you, Dr. Meenakshi, for the next question.
Next question.
Dr. Meenakshi, 1 minute. And Dr. Jyoti, like surgery has a role, but antioxidants at all levels, all stages, yes. Even with facile, yes. Okay, thank you, Dr. Meenakshi. So I think, Dr. Meenakshi, we can repeat Dr. Preeti, Dr. Priyakshi, and Dr. Jyoti. Yeah?
Okay, anyone who wants to take this question? A 32-year-old couple, case of primary infertility, husband occasional smoker, known case of hypothyroidism, wife healthy, all investigations normal. Semen analysis on 2 reports, it was azoospermic. Examination, testes are normal, hormone profile is normal, ultrasound finding is normal. Now, what is Dr. Priyakshi, are you taking this question? Or Dr. Jyoti? Okay, I will take this question.
Okay.
Since can you see, repeat the ultrasound report? Ultrasound is normal. The vesicles are normal. There is nothing. It's a specific. Every finding is normal, but patient is azoospermic. Azoospermic, but they have since history has a role. Yeah, but there is no history or mention of any trauma or any surgery in the past.
No.
Husband is an occasional smoker. We will of course offer them lifestyle modification, like ask them to quit smoking because smoking has an effect. And but in ultrasound they have not mentioned about the VAS, whether it's present or not.
VAS is present.
Okay. So, since the testes are normal, so it could be a case of obstructive azoospermia. So,
How will you differentiate between obstructive and non-obstructive azoospermia?
Because since in ultrasound the testicle size are normal, so and the hormone profile are normal. Hormone that we prescribe are like LH, follicular stimulating hormone, and testosterone. Since you mentioned previously that hormone level are normal, so if LH, FHS, follicular stimulating hormone and testosterone are normal, and testicular volume is normal, so it is most likely a case of obstructive azoospermia. If hormones are on the higher side or the testicular volume is reduced, it could be non-obstructive, or hormones are on the lower side.
Okay.
Okay.
Further investigation, what will you like to advise this patient?
For the investigation, hormonal test is done, but of course we will like to know fructose has a role, serum fructose, semen fructose. We can see this to know the site of obstruction. And since he's a case of thyroidism, hypothyroidism, I will go for TSH, repeat TSH, and to see whether it's controlled or not controlled. No other, because you said VAS is present, so I won't go for genetic.
If VAS was absent, then any specific?
Then I will go for cystic fibrosis transmembrane conduction test here. Genetic testing also to see whether it's a.
The management, what management will you advise to this patient of obstructive azoospermia?
Since it's a case of obstructive, I would advise them for TISA or PISA followed by ICSI.
Okay. There are two options which can be available for the patient. Either the reconstructive surgery in some of the cases, or we can go with the sperm retrieval technique. Reconstruction, if there is vast difference of obstruction, we can repair that. Epididymal obstruction can be repaired. Ejaculatory duct obstruction, when the pH value is acidic, there is ejaculatory duct obstruction. In that case, we can repair it. And otherwise, we can go direct with the sperm retrieval technique, which can be PESA, MESA, TESA. Sir has already explained regarding it. And the obstructive azoospermia cases, the chances of retrieval are very high. We can have a good pregnancy rate with this obstructive azoospermia.
So now this is a 34-year-old army man, fast smoker with 31-year-old healthy wife. हमारे सारे cases में आदमी लोग cigarette तो पीते ही हैं. Repeated analysis is showing azoospermia with bilateral 4 cc testes. The hormonal analysis, you can see FSH is 25.2. We know that the normal value is from 2 to 20 from this lab. Usually after 15, people start calling it hypergonadotrophic hypogonadism, but this lab sticks to 20. The LH is normal, testosterone is on the lower side, prolactin is normal, slightly low estradiol, or I think this is normal for a male. So what is the diagnosis?
Because the testicle size is smaller, normally it is 18 to 20 cc, or so it is testicular. It's most likely a case of testicular failure. And even follicular stimulating hormone is on the higher side, and testosterone is low. So these patients usually don't benefit much, but we can ask them to go for micro TISA.
Yes.
But or for donor sperm.
Yes, it's very easy to tell them to go for donor sperms. In fact, very recently, earlier, whenever I used to, take a presentation on male infertility, I would give them a carry home message that after 15 FSH, it means testicular failure. But interestingly, lately I saw 2-3 cases. One case, the FSH was 37 point something and the other was 25. And we could find sperm. So now I always feel कि जब तक nahi mile tab tak don't say no. And number two, from Dr. Sunil's presentation only, I learned that in such a scenario, we should go for the microdeletion test, the karyotyping for male, and A and B will not benefit. So there's no point in asking them to go for IVF or फिर ढूंढा जब नहीं मिलना. See, this is something which I learned today, and thanks to Dr. Jyoti. Otherwise, I'm not one of those जो बहुत ज़्यादा online वाली classes attend करती हैं. But thank you, Dr. Jyoti. I learned something new today. So this is it. And what does the slide say? Anti-estrogenic aromatase inhibitors, who can benefit? Okay. My one question to anybody and everybody is, when do you use aromatase inhibitors in males? That's one question. And when will you use HCG and HMG? Okay.
Can I answer?
Yeah. Because only we two are there.
Okay. Actually, aromatase inhibitors are used in those males who are like a testosterone estrogen ratio is more, or the obese, usually the obese males who have like estrogen is on higher side.
Yes.
And recombinant HCG is usually in patients where there is a hypogonadism, where in mostly in the gymming person who have taken steroids these days, very common. So HCG has a role in that.
Yes. But one message that whatever form of treatment we are going to give to any male should be given for a period of at least 90 days. As I always always say that males have got a factory और हर 3 महीने में वो fresh stock आएगा. So, past के whatever sins they've done, they've taken lots of alcohol, lots of whatever they've done. If today they decide to live a healthier lifestyle, 3 महीने बाद they'll get a good response. Yeah, Dr. Meenakshi?
Yes, ma'am, true. It's
Do you want to add and finish the last question? Yeah.
Yes. The last one is 33-year-old lean male with unremarkable medical history. He has a history of low libido, sparse beard growth. On examination, gynecomastia is there. Firm testes of low volume. Semen analysis shows azoospermia. Hormone analysis, FSH is on higher side, LH is higher, testosterone is lower side. So now I guess only Dr. Jyoti is there among the panelists.
Okay.
Diagnosis.
Show me. Diagnosis.
Yeah.
Like testicular. Yeah, testicular failure, and because the features are representing some genetic syndrome like a Klinefelter syndrome, because the gynecomastia is there, tall, lean male is there, low libido, beard growth is sparse. So most probably it's a case of Klinefelter. And even in in Klinefelter, the testes are firm. Even if there is no spermatogenesis, usually the testicles are soft. But in these cases, the testicles are firm. So more likely case of Klinefelter. And the test is karyotyping to confirm that.
Fine. And the management option, will you suggest donor sperm in this case or TESE with microdissection?
I would prefer to go for donor sperm in these patients.
Easy one. If
the patient... it's not just easy, Dr. Meenakshi, but the chances of him having if it is a male baby, more, why? I mean, isn't it our social responsibility to give a healthy baby to...
But in Klinefelter syndrome, in some of the cases, we can get healthy baby, but that's very costly if the patient is affording and wants his own child. He should tell him the success rate and the cost which adds on, because the PGD will be required for the baby to know whether the baby is healthy. Plus, micro-TESE is also a difficult decision in this case, whether the retrieval will be there or not. And before going for micro-TESE, if the patient is willing for his own child, we should give some drugs like the testosterone boosters in the form of HCG for 3 months, so that there is upliftment of testosterone hormone. After that, we can go for microtesting. Otherwise, the donor sperm is the next thing.
Dr. Meenakshi, my one question to you is,
Yes, ma'am.
is it microtise or is it donor sperm or whatever? But I think then we have to treat the low testosterone as well. I mean, he's a person by
Yeah.
himself who deserves to be treated and have good, you know.
No, this,
Sexual
yeah,
life.
increase
Yeah.
the sexual life. Yeah.
Physical features will also develop with this.
It's about physical features, but testosterone is also about, you know, power and well-being. It's almost equivalent to female estrogen, I guess, right? The happy hormone for the males is testosterone, I guess.
Yes.
Yeah, so we must remember this as well, that giving a baby is also important, but treating the person, getting his self-confidence back, everything is equally important, no?
True, ma'am.
Okay, so with this slide, I think we've finished our presentation.
Yes, ma'am. It's last.
So, Dr. Jyoti, you should say good to us. We finished quite in time. We've got some time for discussion also. Yeah,
Yeah.
Dr. Meenakshi.
Yeah. So that was a very short but sweet, very crisp sort of a panel discussion. And thank you so much, Mehta Squares, Dr. Mehta and Dr. Meenakshi. You really did very well. Though I think only 3 of our panelists were there, and then we should thank Dr. Jyoti Gupta as well, because she was the only warrior in against the 2 of you. आप दोनों उसके ऊपर bombard कर रहे थे questions, and she was nicely giving.
Thank you,
Thank you so
Dr.
much.
Jyoti.
I mean, sometimes people get stuck up in their maybe OPD or emergencies, and that is why all the panelists could not join. But still, we had a wonderful discussion. 30 participants still here on this particular platform. So I'm sure all of you must have really got some insight into the male infertility, because the male infertility is something, the more we keep on discussing, the more we keep on understanding it. Otherwise, whenever a male with a azoospermia or a low sperm count report comes, our mind gets frozen and we don't know what to do. What to start with that patient, whether to give medical treatment or to do surgical treatment, or to go in for micro TSA and surgical management ICSI along with that. But at least we do have, once we do a good physical examination, we take a good proper history. I think these 2 things, once we go into the habit of talking and examining and taking a proper history of that male partner and the examination, I think half of the things can be solved. And then we go on to the hormonal assays, the Dopplers, then we go on to the medical management and the surgical management finally. And we all have good andrologists in our towns. So thanks to that, we are gradually going, taking care of the male infertility, which is also on the rise. We are taking care of that. So thank you so much, Dr. Manisha, Dr. Sonam Sachdeva and Dr. Shweta, who are the conveners for male infertility. And gradually, in few months, we expect a newsletter also from your particular group. So thank you, everybody. And thank you so much, our chairpersons. And thank you, ISAR Haryana, for your constant support and constant participation. Thank you, Dr. Deepika. Over to you.
Thank you, ma'am. So quickly, I'll take you through the antioxidants that I was pleased to hear Dr. Sunil sir talk about. Our product is also having this L-carnitine that he mentioned, along with lycopene, CoQ10, N-acetylcysteine, and zinc selenium along with L-carnitine. To win the race, we have all these advantage for you to tackle the male infertility. Apart from this, LycoRed-M, we also have Endoreg, Dynogest 2 mg tablets, and Cystilia M, the right combination to restore reproductive health, myoinositol with D-chiroinositol. Please do log into our CSR initiative of Jagsonpal, that is mysakhi.in. Mysakhi.in is having a lot of all the issues we'll be tackling from adolescence till menopause. So we invite you to log into our website, mysakhi.in. Thank you so much.